Much for inviting me, and thanks very much for the introduction. While I'm talking, I can't really see you, so if anybody, if something happens, just speak, if that's all right, or to call me on my phone. That's great. Okay, but I'll just keep going otherwise. Yes, so I'm a neurologist. I'm a clinician. I spend half the week doing clinics such as a dementia clinic, where I diagnose people regularly with Alzheimer's disease. I have a research group called the Remember Group, and I work at the University of Bristol, as well as in the National Health Service. Okay, I'm going to talk about three things today. I'm going to talk a little bit about what the links are between sleep, brain health, and Alzheimer's disease. You probably already know that Alzheimer's disease is the commonest form of dementia. I'm going to talk about how we should measure sleep in people with Alzheimer's disease or at risk of Alzheimer's disease. And I'm going to talk about possible ways we might be able to improve sleep in people with or at risk of Alzheimer's disease. So we've known for years that having Alzheimer's disease means sleep is not as good. So our patients with Alzheimer's disease, dementia, wake up in the night, they nap during the day, they get confused towards the end of the day, they have vivid dreams, and they have behavioural issues overnight, and sleep is very disturbed in Alzheimer's disease. So that is not controversial. What is more controversial is whether or not poor sleep leads to Alzheimer's disease, dementia. It's really important that we understand this, because if we can then improve sleep, we might be able to delay or even prevent Alzheimer's disease. So what is the evidence that poor sleep could actually contribute to developing Alzheimer's disease? Well, there's several levels of evidence we can consider. So if you think about large-scale population studies, epidemiology, there's a really clear story emerging from epidemiology studies. So this is a set of graphs that I've taken from one of a few studies that have looked at UK biobank data. So in the UK biobank, 500,000 people, so 500,000 people in later life, have contributed data, which includes some cognitive tests, lots of information about their general health, and also some imaging such as MRI imaging. And they've also given us some information about their sleep. So the data is quite coarse. It's not fine-grained data, but it covers 500,000 people. And what the story that's been emerging is that there's an optimal time, an optimal sleep duration, and that's around 6 to 8 hours. So here is a study looking at the neuroimaging of the biobank data set, showing that actually brain regional volume is greater in people who sleep between 6 and 8 hours. And if you look, this is not just one small area of the brain, but these multiple brain areas, the volume is biggest in people who have this so-called optimal sleep duration of 6 to 8 hours. You see similar graphs if you look not at brain volume, but at cognitive function, particularly executive function. So executive function is being able to plan and organize things, and also personality and behavior. So we see this optimal sleep duration with people who have higher amounts of sleep having poorer cognition, and people with lower amounts of sleep having poorer cognition, and an optimal sleep duration of about 6 to 8 hours. So if you look at a snapshot in time, we can see that there is an optimal sleep duration. Now, we've also had a whole range of studies that have looked across time, so longitudinal studies, where people have a whole set of tests at baseline and then they're followed up over time. And this is a recent meta-analysis, so it's concluded all these many different cohorts and looked over time, and usually that's up to around a decade. There are some studies that go on longer than that. And overall, it shows a protective window for sleep duration of about 5.6 to 9 hours that helps people avoid dementia. Or put the other way, if you sleep for less than 5.6 hours every night, you're more likely to get dementia in years to come. And if you sleep for longer than 9 hours, you're more likely to get dementia. But if you sleep for between 5.6 and 9 hours, your risk for dementia is less. So there does seem to be a link between sleep duration and brain health and dementia. But these measures of dementia have just really been people being diagnosed, and we know that clinical diagnosis of dementia is very late. So people start to develop some of the proteins that cause Alzheimer's disease up to 20 years before they actually get diagnosed with Alzheimer's disease. And if we can diagnose people earlier and identify the earlier changes, treatments are more likely to be effective. Obviously, it's much better to treat something earlier when people are mildly affected and try and retain their independence. So we can look at these proteins that cause Alzheimer's. So you may well know that the two common proteins that are linked to Alzheimer's disease are phosphorylated tau that causes the extracellular tangles, and the amyloid, the intracellular tangles, and the plaques made of A-beta-42. But we can look for phosphorylated tau and A-beta-42 in spinal fluid. So that's CSF here, cerebrospinal fluid. What we classically see in Alzheimer's is that cerebrospinal fluid drops, amyloid beta-42 drops in cerebrospinal fluid, but phospho-tau increases. And that's because the A-beta-42 is sequestered within the brain, where it should be filtered out, and the phospho-tau is released because of the cells breaking down. So we actually had a look at this in a cohort called the European Prevention of Alzheimer's Disease cohort, with more than 1,000 people who'd had lumbar puncture to check their cerebrospinal fluid for the Alzheimer's disease markers. And what we showed was, as we would expect, that poor sleep was linked at the time to lower A-beta and higher tau. So poor sleep is linked to the markers of Alzheimer's disease. But the really interesting thing, I think, is that if we followed some of these people up and they had more than one lumbar puncture, and sleep disturbance at baseline predicted lower A-beta-42. So abnormal amyloid beta in the CSF after 1.5 was predicted by sleep disturbance. However, the limitation, we're publishing this, well, we hope you are, it's just gone back in and having revisions. So the limitation to this study is that the measure of sleep was pretty crude. It was a questionnaire type measure where we asked people. There have been some other studies, some fairly large, involving hundreds of people, studies where they did what's called polysomnography at baseline. So polysomnography is where people have multiple electrodes, and you can measure the sleep stages and all the electroencephalographic activity overnight, as well as heart rate, and we can actually look at breathing. And they showed that sleep quality at baseline predicted future dementia in people in these larger cohorts. So they didn't have the biomarkers, the A-beta-42 and the tau, they just had the clinical measure of dementia and cognitive impairment. And they showed that there were markers on the polysomnography that predicted decline. So there's quite a lot of evidence linking sleep with future cognitive decline. But what's the mechanism? So then we have to move to mechanistic studies. And to understand those, we really have to remember a little bit about our sleep stages. So forgive me if you're already very familiar with this, but as we go into sleep at night, you go into stage 1 sleep. And in stage 1 sleep, if somebody speaks to you, you've got about a 50% chance of waking up. It's a very light sleep. But rapidly, you cycle into stage 2 and stage 3, so N2 and N3. And in N3, also called deep sleep or slow wave sleep, you start to see these slow oscillations, but around about once a second, but it can be once every 2 or even 4 seconds. So it's between 0.25 hertz and 4 hertz. So between once every 4 seconds and 4 times a second, these slow oscillations that involve multiple brain areas, but particularly linked by the thalamus and the cortex within the brain. So this N3 is this deep state. And if you look at a polysomnogram, you can see this, you can pick out the slow oscillations. After you've been in the deep sleep, then you come out again to REM sleep, rapid eye movement sleep, which is so-called dream sleep. And as the night goes on, you have proportionately more of the dream, the REM sleep, and less of the non-REM sleep. So non-REM, the slow oscillation, slow wave sleep, happens mainly at the start of the night. So that's what this somnogram is showing. It's a duration of sleep. Right, just to mention these slow oscillations. So the slow oscillations happen. This is a slow oscillation, and superimposed on it is something called a sleep spindle, which are much faster. Happen at sort of 12 per second, so 12 to 18 per second, 12 to 18 hertz. And usually these spindles are thought to be really important for memory, so they contain information that you then retain if they coincide with the peak of a slow oscillation. So we can see during this slow wave sleep, you've not only got the slow oscillations, but you've got finer, faster spindles, particularly at the peak, and these slow oscillations help to retain the memories and to make them, rather than being held in the hippocampus, to disseminate memories and distribute across the brain to form a long-term memory. So that's a bit of this background. And the reason why I'm telling you this is because some work that was published in Brain now about 3 years ago, I think really brilliant work, 22 healthy young adults had an automated tracking of their slow wave sleep. And once they hit the slow oscillations, their sleep was disrupted. So they never got into slow wave sleep. And there was also a sham protocol. So it was very well controlled, this study. And what they showed, if you look at graph A, they showed that by disturbing people in the slow wave stage only, it led to A beta 40 actually being higher in the CSF. So in these people who didn't have sticky abnormal A beta 42, they had normal A beta 40, they showed that the production and the filtering was affected by interrupting their slow oscillations, directly linking slow wave sleep with filtering the type of proteins that we know cause Alzheimer's disease. So what's the other evidence that slow oscillations might be important for protecting the brain against Alzheimer's proteins? Well, there's been some work done from a group in California led by Matt Walker, and this study came out in 2020, where they had looked about an average of 3.5 years earlier at people, and they looked at their the levels of amyloid, the abnormal amyloid in their brain in plaques, and they looked at their sleep at baseline, and they showed that if people had fewer slow oscillations, they were more likely to develop pathological Alzheimer's proteins, so the A beta plaques in their brain after 3.7 years. So another mechanistic link between slow oscillations at the start of your sleep and future Alzheimer's proteins. Really interesting here is it wasn't all slow oscillations. It was only the slow oscillations that were really slow. So that becomes complicated because you have to talk about slow oscillations. So this was the slow oscillations that were under 1 hertz in frequency were linked to future Alzheimer's pathology. Right, and then another study that came out in 2019 beautifully demonstrated a direct mechanistic link between a slow oscillation seen using EEG, blood flow seen using BOLD, and a CSF signal moving through the brain, directly suggesting a direct effect of the slow oscillation on CSF through the brain. So, and the CSF, the cerebrospinal fluid, is required to move and filter the proteins that cause Alzheimer's disease. So if you don't have slow oscillations, you don't move blood and then CSF through the brain, and you don't filter away the proteins that cause Alzheimer's disease. Right, so what we're left with is a situation where there is some reasonable circumstantial evidence that poor sleep may lead to Alzheimer's disease, but we haven't yet had the clinical trials. And that's where we are, because I'm a clinician and I run clinical trials. I run several different types of clinical trials, and that's what we want to do next, is because that's the way I think you really prove something, is if we can actually help prevent Alzheimer's disease by improving sleep. I think then we've really got the final piece of the puzzle, and we've proved that poor sleep has contributed to Alzheimer's disease. We haven't done them yet. That's what we're working towards. And one of the major problems we've got with developing clinical trials is that how do we know what aspects of measure to sleep? The sleep to measure, sorry. Well, how do we know what aspects of sleep to measure? So this is not an easy question. It might seem easy that you should measure slow oscillations, but actually, what's important about sleep? So we know that sleep affects the molecules, genetics, and cellular substances within our bodies. We know that there's hormone changes and electrophysiological changes due to sleep. We know that sleep affects cognitive ability, and we know we've just shown you it affects neuropathology, it affects A-beta-42. And what I see in clinic is somebody whose memory is impaired and whose behaviour isn't right. And what should we actually be measuring? What's important to people? What's important? What sort, if we're going to get a drug, what should it actually change? So partly because of the pandemic, we've actually thought about this a little bit more before planning our clinical trials. So one important question to start with is, what is normal sleep? So it might be, again, very easy. We think of normal sleep being about 6 to 8 hours of rest and reduced consciousness level that corresponds to a period of darkness. I think that's fairly straightforward. Some people don't sleep, and that seems to be bad for the brain. But is fragmentation bad like this, or do people need a chunk of sleep? Which, if you get your sleep in little chunks, is that okay? Some people sleep for too long. That's clear. But what about that? If that includes a nap, is that worse? Is that better? We just don't know. And some people sleep at the wrong time, so they'll go to sleep at 3 a.m. and wake up at 10. Is that bad if you get the right amount of sleep? Again, it's not quite clear. Plus, people can't tell us what's going on with their sleep stages and their polysomnography. There's been quite a lot of evidence suggesting that nobody's really got the slightest idea whether they had good quality slow wave sleep the night before. You don't have a subjective idea about your own sleep stages. And from a clinician's point of view, the other thing is loads of people have restless leg syndrome. So there are clinical syndromes that interfere with sleep, restless legs. You need to ask people about it. They won't necessarily tell you that they've got an irresistible urge to move their legs that's stopping them going to sleep unless you ask them. That can be linked to Parkinson's disease, or it can just be something that happens on its own. And sleep apnea, I'm going to talk about in a minute, because that's really common in our patients, and we will miss it unless we ask about it. And then night terrors and vivid dreams. If you have, some people act out their dreams and sort of REM sleep behavior disorder, again, very tightly linked to Parkinson's and other Lewy body diseases. There are all these sleep disorders that we're not very good as clinicians at asking about, and yet they link to a huge number of things. If people don't sleep well, I've been talking about the brain and brain health, but poor sleep is associated with poor cardiovascular health and poor metabolic health and diabetes. So it's sleep. We need as clinicians generally to get better at asking people about sleep and measuring it. So one thing we looked at, because of the pandemic, it was very difficult for us to do data collection in patients, especially older patients who were vulnerable to COVID-19. So we actually reviewed every single study that had looked at people with mild cognitive impairment and dementia, and we saw sleep, and we saw how did they measure sleep, what were they interested in, and the results, we were quite surprised. So there's very little consensus in the field about what's important. We found 165 different metrics. So people have done these studies, and 62 of these metrics were only measured once, and 92 had only been measured once or twice. So people essentially were looking at sleep and reporting a load of different things. And I think that inevitably is because people say, oh, that looks interesting, just pick something that's interesting. So you get a very biased set of reporting in that way. So we have actually proposed a core outcome set. So we've proposed, and actually been really welcomed, a core outcome set to allow people to define what they're going to report. So any study that looks at dementia, mild cognitive impairment and sleep should always report these core outcomes, is what we've said. And they're fairly standard. They're things like total sleep time, sleep latency, the time it takes you to get to sleep, wake after sleep onset, so the amount that you wake up after you've gone to sleep, frequency of those awakenings, whether you nap or not, frequency of naps, and a measure of sleepiness in the day, a measure of some sort of subjective sense of sleep quality, and a measure of agitation. So we can get all those from questionnaires. We can ask people, we can ask carers, and and these are some questionnaires that we use in clinic. So we use the Pittsburgh Sleep Quality Index in our clinic. You can get it online, it's freely available. And also the Epworth Sleepiness Scale. So the Pittsburgh Sleep Quality Index measures sleep quality, different aspects of sleep quality, whereas the Epworth Sleepiness Scale just focuses on sleepiness, which is a marker of sleep apnea. So it's particularly designed to pick up sleep apnea, and we use both in our clinic. But if you look at these core outcomes and all the outcomes that we talked about before, these are things that you really need to have EEG recording or polysomnography to obtain. So we've got a cohort of patients. We've got all my patients coming up. They're usually over 60, over 65. They're often somewhat frail, although not always, and they've got cognitive impairment, and some of them don't have a carer with them or a spouse or someone to help them, and we're saying we need to do polysomnography in people, and this is a typical polysomnography setup, and it has to be done in hospital. So I don't know about you, but I don't think that looks that comfortable. And ideally we would not be doing that sort of polysomnography setup in people who have cognitive impairment. But over the last decade or so, we've had the benefit of neurotechnology. And here's a picture of something called a dream band. There are other brands of EEG headband that you can wear, that are comfortable, you can wear in your own home. And in fact, they're available as consumer devices, so people can buy them online if they want to. And then we can measure sleep stages in people using these devices. But what has never been shown in our population is whether they're actually accurate. So they're quite well validated in younger adults, but are they really accurate in our population? And this is the piece of work we're doing at the moment. So we haven't got any data for you because we're just after the pandemic, we've been allowed to test again. We've set up this study and we've recruited about 15 people who we measure their sleep over 3 months. And they wear a wrist-worn device like my watch, which gives us an idea about their sleep and rest and daytime activity. Then we do an intensive week where we get them to wear an EEG headband, and we look every night at their sleep. And we think it's going well. We think we're going to be able to detect non-REM slow wave sleep, slow oscillations and spindles that we think are important to brain health using these headbands, so we won't have to bring people into hospital to do these sort of trials. But I'll report back to you on that when we've done it, which will be in about 18 months. Right, so final bit of my talk is, how can we improve sleep? So there are loads of ways that we could potentially include sleep, and one of the main problems is deciding what's most likely to help older people. So one way to improve sleep is to improve wake. So if people are really awake, if they go outside, they get light, they get their circadian rhythm stimulated. If you avoid napping in the day, or at least you limit naps in the day, don't drink too much, don't have caffeine before bed, all these sort of things. So to make sure when you're awake, you do things that help your sleep. That's likely to be very helpful. Another thing is just psychological things, so bedtime routines that trigger sleepiness, avoiding bright lights at night. And then there's been a lot of news in the last week in the UK about using cognitive behavioural therapy, so CBT, to try and help insomnia, and it looks very promising. And in fact, it's now been prioritised above any drugs for insomnia. So people should try CBT, try psychological therapies before they try drugs for insomnia. But we don't know if that works in people with mild cognitive impairment or dementia, or older people generally. And then there are specific things that can target non-REM sleep. So it's really, I'm not going to talk much about it, but there's really interesting acoustic stimulations during slow wave sleep. If you have oscillations, then one can stimulate the slow oscillations and prolong them. So, but obviously, if you play the sound too loud, you can wake people up. So you have to titrate the sound properly. But that would be a very non-invasive way to try and boost non-REM sleep. There are drugs that could potentially boost REM sleep. And also, we're just looking at the sleep environment. So not having, well, we did a questionnaire and asked people what interrupted their sleep, and loads of people said it was their pets. So they sleep with dogs and cats, and they get bashed in the head overnight. And I mean, as someone who thinks sleep is important for brain health, it seems sensible not for that not to happen. But obviously, people love their pets, and they don't want to get rid of them. Anyway, one thing I'm going to talk about next is the comorbidity. So if people are in pain, if they need to get up to go to the loo, if they're very restless because of that restless leg syndrome, that can be a problem. But sleep apnea is a major issue that we overlook in our patients. So sleep apnea is when you make a respiratory effort, but there's an obstruction. This is obstructive sleep apnea. So the upper airway is closed, the soft palate folds down, so you can't, but you're breathing out against an obstruction, and it raises your intrathoracic and then intracranial pressure. And the way that most of us are familiar with the sleep apnea is listening to somebody snore, and then there's a pause in the snoring. And this is incredibly common. And mild sleep apnea, you'd have a pause where your oxygenation dropped by 4%. 5 times an hour or less. Moderate sleep apnea is 5 to 15 times an hour, and severe sleep apnea is over 15 times an hour. It's not that unusual for it to be 30, 40, 50 times an hour, where your oxygenation dips down and through the whole of your sleep, incredibly disruptive to sleep cycles. So we know that if people have all these arousals, they never develop full slow wave sleep. They never get into proper non-REM or REM. They just have light sleep the whole night. People can feel tired the next morning. They can get a headache, and then they're drowsy. Driving is an issue. People fall asleep at the wheel. So sleep apnea has huge impact on day-to-day life. And look at this. So look at this table here. So most of our patients are 50 to 70. If you look at men at the top and women at the bottom, and then if you look at the BMI, so most of our patients have got a BMI between 30 and about 35. So they're in this bottom group here. So in men, that's about 25% of our patients will have sleep apnea, and about 10% of women will have sleep apnea. And yet we did a survey around clinics around the UK, all the different countries in the UK, and we found that about 2% of people, the clinicians estimated about 2% of people were being treated for sleep apnea. Most people don't have a validated way to screen for sleep apnea in their clinic. They don't use something like the Epworth questionnaire that I told you about earlier to screen for sleep apnea. We've started doing it in our clinic, and we're picking up far more sleep apnea and referring a lot more people for treatment. And it can be treated. So it's really important, because then you can restore sleep. You can get people back to having reasonable slow wave sleep. And the other really tricky thing about sleep apnea is there's some work being done in Sydney that's not been formally written up yet, as far as I know, but it seems to suggest that people in the early stages of Alzheimer's who have sleep apnea may not always be sleepy. So they might present differently to people without Alzheimer's. So we might actually be missing sleep apnea in our patients because we're using this sort of questionnaires that are suitable for everybody else, but not for them. So there's been a model described here that links sleep apnea, OSA is obstructive sleep apnea, through reducing slow wave activity, increasing A beta release, increasing A beta aggregation, and then the plaques, and getting symptomatic AD. So there's a proposed link directly between sleep apnea and Alzheimer's disease. And the positive thing is, in this study, which was reported a few years ago, they looked at people who were treated for their sleep apnea, and what they showed was the normal benefits that you'd expect, i.e. sleep improved, but actually critically A beta 42 changed. So by treating sleep apnea, we were able to modify the accumulation of amyloid beta plaques. So it's very promising, and this is a trial that is just waiting to be done. And if we can get the money to do it, we'll be doing it. Okay, so that's the end of sleep apnea. I'm now, for the last like 10 minutes of my talk, I'm going to talk a little bit about some work we've been doing that's completely different, and it's with levodopa. So levodopa, those of you who are prescribing or planning to be prescribing at some stage, levodopa is the commonest drug used to treat Parkinson's disease. It's given as a tablet. It's given with a dopa decarboxylase inhibitor in a formulation that means that it's not metabolized until it gets into the central nervous system, and in the central nervous system you get dopamine, and so it boosts the levels of dopamine, and that's very useful for people with Parkinson's. We can see if we give them, someone with Parkinson's who's shaky and slow, we give them some levodopa, we can see that they improve within sort of half an hour or so. When you look back to the 1960s and 70s, when levodopa was being first trialed, one of the major limitations was sleepiness. So we've known for years that levodopa causes sleepiness. In fact, 5 to 10% of people with Parkinson's, their use is limited because it causes sleepiness. So we did some work many years ago where we looked at using levodopa, and we looked at long-term memory on levodopa. And what we showed, to cut a very long story short, was that long-term memory seemed a bit better in people on levodopa, which we hadn't expected. And these were people with Parkinson's, and we took them on and off their levodopa. So this, who was the person, John Grogan, was one of my PhD students, is now a postdoc. He tested this in a bit more detail, again with people with Parkinson's, to test whether levodopa really did improve memory. And we did a very complicated regime that I'll try and skim over in a way that's not too complicated. So we took people who each did 4 different testing sessions. And in 2 of the testing sessions, we took them off their levodopa, which is in red here, for the night before learning. And in 2 of them, they were on their levodopa the night before we got them to learn. And then they, everybody went back on their levodopa. And then in 2 of the testing sessions, we took people off their levodopa over the next night before we tested them. And in the other 2, they stayed on the levodopa. So they were either on and on and off and on, or off and off levodopa. And that's 2 different nights. And the test we used was a very simple word list. So we just got people to learn 12 words, and then we tested their memory for those words. We read them out 3 times, and then we tested their memory for those words at 30 minutes, and then again after 24 hours. Right, so what we showed was not really what we'd expected, and it sort of made the story a bit more complicated. So if you look at the lines on here, so the black line is healthy participants who obviously did better across the board. So, and what we're looking at is memory at 30 minutes compared to memory at 24 hours. And if you look at the continuous red and blue lines, so not the dashed lines, the continuous lines, memory is a little bit better in those 2 than it is in the matched dashed lines, red and blue. So a red continuous line, memory is a little bit better at 24 hours than a red dashed line. And the difference between those 2 is that people were on levodopa overnight before testing. And the same pattern is there for the blue continuous line compared to the blue dashed line. If you have people on levodopa the night before testing, their memory is slightly better than if you take them off. But if you have them on levodopa during the day, which is red versus blue, then the memory is slightly worse. So, so in blue, memory is generally worse than in red, and that's the people who were on the levodopa during the day before, when they were learning. So there's a difference between levodopa overnight and levodopa during the day. And this made us think, oh, well, levodopa makes you sleepy, and it seems to benefit memory overnight. Maybe levodopa is improving nighttime sleep, which is important because millions of people around the world are already prescribed levodopa. And if we know that actually giving it at night is quite good, whereas giving it in the day is less good for memory, but giving it at night is good for memory and sleep, we should do that. So we decided to test that even further. And we looked a little bit at the literature, and we saw that actually there's a rationale for this. There's this review, if you're interested, by Feld and Bourne, which suggests that levodopa biases memory, and some of that may happen during sleep. And there's some beautiful Drosophila work coming from Ronald Davis at Scripps Institute in Florida, suggesting that there are dopaminergic mechanisms in Drosophila, so fruit flies, for forgetting and retaining information. So we came at it from a human perspective, but actually when we looked at that, and then from a patient perspective, when we looked across the cognitive neuroscience literature and then the animal model literature, we found some fairly good rationale to justify looking at the impact of dopamine on memory. So another PhD student called Hannah Isotalis set up a study called Dopamind. And the question that we were asking was, does levodopa improve memory through enhancing sleep? And this time, rather than using Parkinson's patients, we looked at 35 cognitively normal older adults. And we did it in a really robust way. So we used double-blind, single-dose, overnight, order randomized, crossover placebo-controlled trial of a levodopa preparation. And we measured, our main outcome measures were, firstly, what was their memory like after having levodopa? And secondly, what happened to their sleep? So we did polysomnography. So you remember that uncomfortable setup when people came into the lab? That's what we did. We brought them into a lab and they stayed there for 2 nights. One night they had placebo, one night they had levodopa. I'll show you a timeline now for what we did in the study. So we got them to learn 80 words, and we knew that these words were divided into 4 lists, A, B, C, D. They didn't know that. They just saw loads of words. And the 4 lists were intermingled. So they learned those 4 lists. They learned 80 words. We then gave them some levodopa, and then just with one of those lists, so with 20 of the words, we got them to relearn it. So we kind of tagged those words, made them important, made them reconsolidate and think about those words. But just 20 of them, the list A. So those were our kind of strong memories, if you like, and that they were triggered after being given levodopa. The next morning, we then tested the memory for lists A and B. So A was a strong memory, B was just been done before and just once. And then on day 3 and day 5, we tested 20 other words, list C and list D. So essentially, we got people to learn something, we gave them levodopa, we reminded them of a proportion of what they'd learned. Then the next morning, we tested whether or not they could remember it, and we did the same on 3 and 5. We also measured their sleep on the night after they had the levodopa. So we used some linear mixed modelling, and that's really to compensate for missing sessions. We didn't have a lot of missing data, but this is a way that we don't lose a whole participant if just one of their bits of data is missing. We did look at, I'm not going to report on dose, but it's in the paper, but we looked at the effect of time, the day after, or day 3 or day 5, and we looked at D prime. So we looked at memory using D prime as a marker of sensitivity or accuracy. It just means the number of words they get right compared to the number of words they get wrong. So our first result was, this was not what we were expecting. So levodopa increased forgetting for the weak memory traces, so the ones that weren't repeated. So if you just look at day 1, people remembered more when they took placebo than when they took levodopa. Day 3 and day 5, we saw the effect went away, so that suggests the forgetting or the loss of memory was accelerated, but it wasn't overall. The overall memory trace wasn't lost because they were the same by day 3 and day 5. So there you can see day 3 and day 5 completely, by the time we get to day 5, doesn't matter whether you had levodopa or not. So it just seems that it accelerates a process that was happening anyway. At least that's our explanation. We'll wait to see if that's correct. But remember, this is all looking at the list that wasn't repeated, the weak information. So remember that list A that was repeated, that was a strong memory. Well, there was a trend, although it wasn't significant, towards levodopa improving memory for strong items. So it seems that overall there was a bigger separation between strong and weak items, driven by the loss of the weak items on levodopa than off it. So it looks like maybe levodopa was biasing memory there. But then we move on to sleep, which is where the sort of positive side of this study came out, in that, remember that slow wave sleep that we think is important for brain health? Well, we actually increased slow wave sleep duration by about 11%. And you can see this graph here shows the number of people above 0 who had an increase in slow wave sleep duration compared to the number of people who had a decrease. So most people had an increase. And some of this work was done by Will Carr, who's another PhD student who's worked with us. And then Will went on to look, you remember those spindles that I told you about, that with the high frequency oscillations, actually a really striking effect on spindle amplitude. So people who had levodopa, the size of those spindles went up. Which we weren't expecting. This was a post-hoc analysis, so it's exploratory, but it was really quite convincing. If you look at, there's relatively few people who had a reduced spindle amplitude and many people who had an increased spindle amplitude. You can see from that scatter plot. And when we looked at spindle amplitude, compared the change in spindle amplitude caused by levodopa with the difference between those strong and weak memories, we saw a reasonable correlation, suggesting that there's something to do with the spindle amplitude that affects or relates to the way that memories are biased towards strong and away from weak memories. Remember that those spindles coincide with the slow oscillations, and what we showed was that the effect of dopamine on spindle amplitude was at the peak of the slow oscillation, so kind of the bit that affects memory, we know that. So we're quite interested in that. That's our finding. As with most of the research I've ever done, it's resulted in more questions than answers. So it looks like levodopa increases efficiency of forgetting or makes people remembering less good, but it normalizes. That's only over one night. After that time, it normalizes. We increase the duration of slow wave sleep, which could that be helpful to people who, given the slow wave sleep protects brain health? And we increase spindle amplitude. So we've now got another study running called Dopamine 2, where we're testing people with very early Alzheimer's with levodopa to see what the effect of levodopa is on their sleep and memory. So we're also interested in exploring other interventions, so lifestyle, physical activity, bright light, and we're just going to work through until we find a way of helping our patients. So the conclusions overall are that, to my mind, there's fairly convincing epidemiological and mechanistic links between sleep and brain health. We still need to work on how to run these trials so we can do them in people's homes, and we're trying to accumulate the data to do that. And there are several potential treatment avenues, and so there's a lot of scope for improving sleep in people at risk of Alzheimer's, and we could actually have a real world impact in reducing. And remember, we only need to delay Alzheimer's onset by about 3 years, and we cut in half the number of cases, because Alzheimer's happens very late in life, and so delaying the onset would have a huge impact. So that's what we're going to work on. And this is my group, who are brilliant, I think. And this is up at World Sleep. So this is our first post-pandemic conference in Rome, where we presented some of this work. So thanks very much. I'm going to